Hi everyone, my name is Tiara Brooks, and here at School-Based Health Alliance, we would like to thank everyone for attending today's webinar, Quality Improvement 101 Part 1. This webinar is the first of a three-part series. You will hear how to employ PDSAs and performance measurement in an effective and even fun way without driving yourself crazy with extra work. But before we begin, we have a few housekeeping reminders. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based health care. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to health care services. School-based health care is the solution, bringing health care to where students already spend the majority of their time in school. When health and education come together, great things happen. Attendance improves. Conditions like asthma and diabetes are better managed. Behavioral health issues get quick, expert attention. And we all know that healthy students make better learners. First, please help us with our attendance count. If you are viewing as a group, please go to the chat window in the question box and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the question box located in your GoToWebinar control window. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that will meet your needs. This webinar is being recorded and will be archived along with the slides on our website in 3 to 5 business days. Please also visit School-Based Health Alliance for additional archive webinars for topics such as the ones you are viewing on your screen. Attention, please register today for our 2016 National School-Based Healthcare Convention and Rally. It will be held in Arlington, Virginia, June 26th through the 29th. We hope you'll join us for another year of innovative workshops and engaging speakers. Now, I would like to introduce our presenter today, Hunter Gatewood. Hunter is a social worker and quality improvement educator and consultant. He specializes in the intersection of quality improvement methods, management skills, and leadership development. His clients include primary care health centers, hospitals, health plans, medical groups, behavioral health agencies, grant makers in elementary school and a high school. His clinical experience includes hospital social work and community case management for those patients with high care needs related to homelessness, substance abuse, complex medical conditions, and mental illness. Again, thank you everyone for attending today's webinar. I would now like to turn it over to our presenter, Hunter Gatewood.
Hi, thanks. So we are going to share my screen. So let me get to all right. Hi, everybody. Sorry, I'm getting organized here. There we are. All right. How does that look, Tiara? You got it?
Great. Yep.
Great. Okay. Good. Hi, everybody. Really happy to be with you. I'm a huge fan of school-based health and health clinics in general. I know not all of you work in school-based health centers. As the intro said, as Tiara said, I am a social worker and did a lot of work with mostly homeless adults in San Francisco before I started doing improvement work full-time. So happy to be with you guys and talk about some of my favorite topics that I've really seen this PDSAs and the model for improvement work really well across hundreds of clinics now. Not every clinic has been able to hardwire it as well as every other, but I've worked with hundreds of clinics by this point and really believe in this methodology and happy to share with you all. Can we do our first poll question?
Definitely. Our first poll question, have you ever been a part of a clinic improvement project using monthly measures and PDSAs? If you can just take a few seconds to answer the question. Thank you.
Okay, how's it looking?
We'll be able to view it once we finish the poll question. Okay, great. Thank you, everyone. So we have 69% that said yes and 31% that said no.
Great, that's good. I'm glad that there's that much experience on the line. So please use questions as we go. We'll pause for questions once or twice, definitely at the end. And Tiara, if there's some really exciting questions and you want to interrupt me as we go because there's this much experience on the line, that is fine with me.
Okay, perfect.
And are you, yeah, and did the poll question, are you still seeing my slide here?
We are not in slideshow view, but we can see your slide.
Oh, okay, I'm sorry. Let me make sure it's in the right view because it's the right thing. Let's see. Sorry, everybody. Let's see. Okay, there we go. All right, thanks. Okay, so let's talk about this. So we're going to talk about PDSAs. But of course, PDSAs are one part of organized quality improvement efforts. So if you would chat in, and Tiara, if you just read off a few things, what do you think of when you think of quality improvement? Just a few phrases. What does it look like? Who does the work? What's the point of it? What does this phrase mean to you in terms of observable activities and participation?
Okay, perfect. If you guys can use your question box located in your GoToWebinar. Okay, we have work continual process, small scale test, team-based, quick results, we have measuring performance over time, staff buy-in, and quite a few others rolling in there. All right. Making things better, enhancing outcomes, evidence-based, pursuit of perfection. Looking for what's not working.
Right. Okay. Thank you, everybody. Let's pause there, and that's. You will see that you've covered a lot of what's on my next slide and a lot of what we're going to be talking about for the rest of the hour. So this is great. Yeah, it's to someone said better. How do we do things better? It is about how do we do things better, and in terms of, I like to think about the perspective or the approach being change at the system level, where the system is your overall clinic, and I think of a system as the unit of work. It's the organization, it's the clinic, and the system is the sum of all of the processes you do. As you see visits, as you do outreach to patients and kids, as you, in a school-based health center, as you coordinate with the school faculty and work on community and population health in that environment, it's the system. It's all the people that work there and all the work that they do together as a group makes the system of performance. And the goal, as people said, is to, what do people say, improve outcomes, figure out what's not working, let's see, get buy-in, quick results. So yeah, it's work by the frontline teams. This is one of my favorite things about quality improvement, about, within which PDSAs are a big part, is that it's allowing the people who aren't the managers to actually figure out what works, the frontline experts, the frontline staff. Often these are people who've never been asked their opinion before about how the work should be done. They come to work every day, they sit down, they do their hard, they do their best, and often do not get included in meetings where change management happens, where big decisions about how we should change our processes work. So that's one of my favorite parts about this, that everybody gets to be an expert in their own job. People mentioned measurement and improving outcomes. Absolutely. It's regular ongoing measurement. Using quality improvement requires us to measure more frequently than annually when the HEDIS measures and UDS measures are due. And we'll talk about that in a minute too as we talk about the overall model within which PDSAs fit. And the idea, the purpose of all of this is to reduce variation so that we can get better results and to find out what works and implement it. So here's my little conniption fit. It's going to be a little subdued because it's raining where I am today. I'm kind of feeling mellow. But here's my little modified conniption for you. Please, please, please don't do quality improvement just because, I don't know, just because you have a grant or just because it's a short-term project. Don't do it if you aren't ready and willing and have commitment by the leadership particularly and the frontline staff to make lasting changes. It's not worth doing quality improvement if you're not in it for figuring out what new ideas you can figure out, what evidence-based ideas you can find to fix what's not working. You want to come out of quality improvement work with sustainable changes that are really going to impact the care you give for your population, and where you're not doing it just for the sake of a project. My other little conniption fit, these are very subdued conniptions, is please, please, please don't call it the PDSA model. There's more to quality improvement than doing these fun, rapid, small-scale experiments. And so I hope people, I try to help people not say PDSA model because the PDSA is very important. PDSA is not the same thing as measurement. Testing something small is not the same thing as implementing something that's going to work long-term. So if you would like to take that directive from me, that's what I would love for people to stop saying PDSA model. Okay, and as we think about some of the words that have come up so far, I just want you to have these in your head. To answer the question of why do we need to use an organized methodology that we'll go into more in a second here. Why do we need a methodology for change management and figuring out what works and implementing it? Why can't we just do it? Why can't we just take the evidence-based practice that's working somewhere else and put it down? It's because your system, your clinic, all the work that you do is different than the work that happens other places. Every system is unique, and because the work is complex. There's no one, not me, not your medical director, not your CEO, not the executive director of the clinic down the street. Nobody can say exactly what's going to work in your setting with your unique set of patients and families you work with your unique number of exam rooms and staff. And so we talk about complexity versus complicated. If you don't know that, that's an important idea in change management. Complicated was the moon launch. Landing a rocket on the moon was very complicated. Hard to hit that moving target, miles and miles and miles out there in the sky. But it was doable, and if enough people, enough scientists worked specifically on doing all that math and figuring out jet propulsion and all those things, I have no idea about rocket science. You can use rocket science to figure out how to land that rocket on the moon. Complex is where the conditions are so variable, there's no single formula or no single set of management ideas that will get that perfect result. Complex is raising a child. I don't have kids, but I know a lot of kids, I know a lot of parents. Every kid is different, every parenting situation is different, every parent is different, and so complex means there's no way for us to write down a recipe for how you succeed, and that's certainly the way healthcare is. Healthcare is complex, and so everybody needs to have this methodology, have a fit process where they can figure out for themselves what works out of all the best practices in the world and what they want to standardize. And again, back to my little mellow conniption, if you're not in it in order to figure out what you can standardize to get a reliable process, I recommend not using the methodology, not trying to do all the work of measurement and all that stuff if you're not really in it to standardize what works. The big question here, how can we get where we need to go? How can we improve things for our patients while we keep doing our work every day? You can't close the clinic for a month to figure it all out. So how do you use the methodology, including these small PDSA tests that happen during the workday, allow you to make changes without, again, without driving everybody nuts and while you're still seeing patients. Okay, here's a kick in the head that may not be a new kick in the head for a lot of you because of your experience in organized improvement work, every system, or we could say every clinic, is perfectly designed to give the results that it gets. In other words, you can only get results, you can only do things in your work to get results that your system has been intentionally designed to do. So if the first, let's see, if you have a lot of unused visits, if the kid who needs both primary physical care and behavioral health care can't get those both in the same visit or close to each other, it's hard to make that connection and get both of those types of services delivered. If the first visit of the day never starts on time and you're behind schedule all day, if you can never get those parent permissions forms back to do all the good work you need to do with patients, that lack or that need or that deficit, to use a harsh word, is inherent in the design of your system. Not that you're doing bad work, not that your team isn't smart enough to figure it out. You just haven't perhaps stopped recently to figure out how to focus on that, what it is that you can do in an organized way to get those results. So we get the results we get because of the way our system is set up intentionally and accidentally. It's important. A distinction that's important for people to hear, especially when they're new to quality improvement, is that quality improvement is not the same thing as quality assurance. Quality assurance uses inspection, external audits. It's the dude with the magnifying glass looking at us and saying, are you doing things right? Are you meeting regulatory requirements? Are you, keeping to the HIPAA regulations and FERPA regulations if you work in a school? It's important. We got to have quality assurance. We want that. We want services we use for us and our families. We want Chipotle to be accountable for the E. coli. We want that external audit and inspection. But quality improvement is us fixing things based on what is important to us, and not a process where external auditors come in or we're auditing ourselves. Again, it's quality improvement. It's us doing things to fix our work from now going forward into the future. Quality assurance can only look into the past. Quality assurance is intrinsically historic, right? It's only looking at what's happened already. Quality improvement is about what's happening, what we're going to do to make things better for our population and our workflows and our processes in the future. Okay, so here it is. You've all seen this before. The model for improvement, 3 big questions, and the little testing wheel, the big testing wheel here at the bottom, the Plan, Do, Study, Act cycle that we'll talk about. That's the focus of our webinar today. But I want you to see that there are 3 other questions. There's other stuff here besides our testing wheel here at the bottom. So to summarize the model for improvement, what are we trying to accomplish? That's our aim. That's our measurable time-bound goal. How will we know that it changes as improvement? Well, you're going to do the frequent measurement to figure out what's working, to figure out what's not working so you can stop doing things that aren't working. And then the third question, what changes can we make that will result in an improvement? This is what someone was referring to when they chatted in before, evidence-based, right? There's all these cool things that people are doing elsewhere. It's kind of overwhelming, all the things we can try, but we're going to try things in an organized way using this methodology to see what happens. And again, the Plan, Do, Study, Act cycle is for rapid tests of changes. So when you look at the model here, I want you to look at it I want you to think about it like this. It's not a big, fat, single Plan, Do, Study, Act cycle. It's a whole bunch of little Plan, Do, Study, Act cycles, right? That helps you figure out what changes we can make that will result in improvement, which best practices work for us, and how do we need to modify them, which then, continuing to go back up the model for improvement, then once you figure out what changes work for you, you believe that that's going to lead to an improvement in your measure. For example, the measure of how many children get their BMI screenings at the right interval. How many people are screened for depression? Is something you can measure. How long do people wait for a regular appointment? How long do our appointments take? Those are all things you can measure. And then ultimately, as you succeed on the measures, you're going to succeed on your aim. So that's the way I want you to think when you see this model for improvement. Okay, so a couple of examples, some examples of aims before, and again, we are going to dig into PDSAs for sure, but we need to start with this context and the big picture here. So an aim is what we're trying to accomplish. This is your SMART goal. By when? By, for example, June 2017, we are going to improve asthma care for our patients in our clinic with asthma and we're going to use measures. We're going to use a few measures about asthma education, self-management. Do they have an asthma action plan? That's going to give us our numbers, our numeric information about what it is now, how many kids have asthma action plans, to how many kids will in the future, what our target is for asthma action plans, what our target is for people having a current prescription of both kinds of inhalers, so they're not just relying on their rescue inhaler, and all those things. Okay, so here's some examples. I'm not going to read them, but I just want you to look at them for a second, and then we're going to do the second poll question in about a minute. So you can see that all of these are organized with the by when. There is a time-bound goal point by which we as a team are really going to do everything we can to reach that target by the end of that period, and the target is numeric. You all know what SMART goals are. This is similar to SMART goals: specific, measurable, achievable, relevant, and time-bound. That's what the aim statement is. And then all the measures, the second big question, how do we know that a change is an improvement? Those measures help us figure out, are we reaching that aim by the end of the period? Okay, let's do poll question number 2 about topics that people are either working on currently or would like to work on an improvement project on.
Yes, if you see on your screen, what is a clinical condition or operational challenge where future organized improvement project may be useful? Okay, thank you, everyone. All right, Hunter, we have 67% that said clinic operations revenue max, 49% behavioral health, 48% exercise and wellness, weight loss, nutrition, and 37% sexual health.
Thank you, that's great. So I'm going to try to weave in some examples from, let's see, from the top 2 or 3. It's a pretty good distribution, but yeah, most people really want to work on clinic operations and revenue maximization, which is good to see. It's a newer topic for a lot of clinics, but very important as we think about this era of capitation managed care and the role specifically for those of you in school-based health centers. So that's great. Thanks, everybody. Okay, so we're going to move on to the second big question, and then we'll really dig into PDSAs. So for measures, again, what are we measuring? Where are we going to go? The main thing I want to point out here is that there's a lot of different things you can measure. You can measure, I don't know, you can measure how many times your improvement team is meeting. You can measure how often people show up for work. You can measure all kinds of things. But for a good aim, a good improvement project, you really want to make sure that you're focusing the goals on the health and services to the population of patients. We can meet every day for 3 hours a day and have it be an improvement meeting, and that can all happen, and we can look good when we measure that. But that may or may not be the thing that really actually leads to improvement for the population of patients. So especially when we're thinking about clinical topics as different from clinic operations topics. So when we're thinking about clinical topics, you want to make sure that the population and what they need shows up in the aim. Or sorry, shows up in the aim and the measures. Okay. So here's a starter set of measures, clinical and operational. I won't read them, but just to kind of keep your head in the category of measures here for a second. Okay, and some at the bottom relate to the clinic operations and revenue max that 67% of you said you are interested in working on, or maybe you're already working on. So those are some measures, and again, those tuck up underneath the categorical aim of operational efficiency or clinical quality. For your overall aim could be about asthma or well child visits and screenings. All right, so here we are now. We're going to dig into the reason you're on the phone, the topic of today's webinar. We're going to really get into this part of the model for improvement, the quality improvement methodology that's about these rapid tests of change, these plan, do, study, act cycles. But first, let's talk about, so when we talk about plan, do, study, act cycles, we're going to talk about how they work, the pieces of them in a minute. But the big question is, why do all these small tests of change? Why can't we just take what we learned from another clinic about how they do group visits, or about how they do parent outreach, or about how they do screenings, en masse in the high school using they have a taco day. There's a clinic in Oakland that I know that does that, and it works really well for them. Why can't we just get on with it and do the thing? Because of this. Because everybody has opinions, and when you bring people together, we're imagining the woman in the kind of grayish sweater here. She's pointing at something. She's been to a conference, and she has the right idea, and she wants to do things like they do somewhere else. And that's great. We all get excited when we go to conferences and learn best practices. And the instinct is, in a lot of places, is, gosh, we're really busy. That's a great idea. Sure, that's cool. I'm glad it worked for them. I'm excited. Let's just do it. But often what happens when you try to just implement something is that you are not proceeding as a team. You don't have that buy-in that somebody mentioned earlier when they talked about what quality improvement is and how it works. You can, somebody might think all these things. They might also think, gosh, yeah, we worked on that. We worked on asthma improvement 10 years ago. And we did okay with it for a little while, but then it faded because there was a new project. So the idea for the PDSA small test of change is that it helps you get buy-in. It helps you figure out what works specifically for you so that you can maintain it over time, so that it's not just a fun little experiment to do and then you forget about it in 3 months because you're already moving on to another priority, or you didn't keep track of it using a specific methodology like a small test of change related to ongoing measurement. So here's a list. I think we've covered it. It's about adapting. It's about gaining buy-in. It's just the concept that you don't know till you try. We can't figure out exactly how a best practice or a new idea, no matter how wonderful or effective it is somewhere else, we don't know until we try it how it's going to work out for us. All right, and so now we will get into how these rapid tests work in the real world. What are the steps of a plan, do, study, act cycle? So the plan is, this is a team activity. Everything on here except for the do part where the plan is carried out, the experiment's carried out, everything here is a team activity. That's why we want to use a formal structure. That's why there's this cycle. That's why there's a plan, do, study, act form that I really strongly recommend you use, particularly with a new team getting up and going with PDSAs. It's important for the team to plan and for the team to make decisions, and not just for the person doing the experiment or with the bright idea to run off and carry it off themselves and just tell everybody what worked and what didn't, make those decisions themselves. Quality improvement is a team sport because we need everybody's expertise. Okay, so plan. You're sitting at the table like the women in the photo a couple slides ago. You are working on improving something. You're working on improving attendees for a parenting class that you're doing. Say that you're working with little kids, with the tiniest kids, and you're doing a parenting class for new moms. And you're trying to get people to show up for the class. We can't do the group if nobody shows up. So the question is, what can we do to improve attendance for our new moms class? That's the question. So that's what you're trying to answer with this small test, this small experiment. And so you come up with a plan. The plan is you're going to use texting for the new moms that you have targeted for the group. You're going to text them, and you are going to offer an opportunity to get a $50 gift card for a grocery store that you'll be giving it out at the class coming up next week. And you're going to see how that works. Because you don't want to go out and buy a bunch of gift cards if it doesn't work, if it doesn't improve attendance, if people don't respond to the offer, that's wasted money and wasted time and resources. So you want to test it before you go out and spend, I don't know, your $800 grant on a bunch of gift cards. Okay. The do is carrying out the plan. So now that you have this plan that you made as a team, the woman, we'll call her Shiloh, she runs the moms group. She's going to carry out the plan. She's going to text the moms, and she's going to keep track of of how it goes with the texting, and she's going to see the do carries all the way through the group because you got to see who showed up. When we think of data for a plan, do, study, act cycle, a lot of people want to look at their regular monthly measures. So they might want to look at measures of how many moms who attended the group got their weight checked or got screened for postpartum depression or anxiety. We're not really looking at the whole population here. We're just looking at the group of people who showed up for the visit, and we're just looking with a PDSA. The only data you really need is information on information on how well the test worked. So data may be even a strong word here. We can think about it as just information about how the test carried out. Okay, so that's the do. Shiloh does the texting, has the group, and she sees what happened. She keeps track of how many moms showed up, what they thought about the texting, and then study. Again, we're back to a team activity. Not for Shiloh to decide by herself what worked and what didn't. You can throw a lot of babies out with the bathwater if you do the study as a solo person. Again, this whole format, using a form, the formal structure here is in order that the team brain can work together versus one person making these decisions on behalf of the whole team. We don't want to throw out good ideas just because Shiloh ended up having to run the group by herself because somebody didn't show up to work, or one of the moms yelled at her about texting her because her phone plan charged her and she's very low income. We don't want one part of the test that didn't go well to lead the whole team to say, okay, well, we can't use texting or gift cards. You don't want to throw out the baby with the bathwater. So study as a team activity. You look at what happened with the test, what can we use, what didn't work, and then the last step is based on the study, based on, again, that team discussion. That's the act, and you've got 3 options there: adapt, adopt, and abandon. Adapt is the most normal one to happen, especially when you're doing your first PDSAs. You're going to want to tweak it. You're going to want to make some changes to how you text people, how many gift cards you offer, how close to the group day you text. There's all kinds of things you'll learn, ideas for how to keep doing this type of PDSA on the same topic to answer the same question, but to make a few changes. So that's adapt, and you would run another test. Adopt is, wow, that worked really well. We want to move from the testing phase to the implementation phase, so we're going to adopt it. This is our new normal. Every time we do a group visit, we're going to offer these gift cards. We're going to do the texting. It worked really well, no bad effects, didn't take Shiloh too much time away from her other duties. This is awesome. We're so clever. This is great. We're going to adopt this change. And then you're in the implementation phase with texting and gift cards for encouraging group attendance, right? And so then you would do it across other groups. You might do it every week, or you might do it at the beginning of every group that starts up for depression, for healthy weight, however many groups you do. So that's adopt, and that's a big decision because then you have to communicate it out to the whole clinic, everybody who's running groups in this case. You would then need to, you'd need to make sure you had enough money to do the gift cards, and you would need to train people. Maybe even if it's a big change, write it into people's job descriptions. Okay, and then abandon I like because that is really a lot of the value of doing PDSAs in the first place. Abandon is when you do a small test and you do it on one day or in 1 or 2 weeks, and 1 or 2 people are involved and just a few patients are involved because it's a small test, and it's a total disaster. And that's wonderful because you didn't rush to implementation. You didn't take the idea from a conference and just implement it like that because it worked somewhere else. You took the time to structure a small test, and it really didn't work for us. This test, I'm glad it worked for the clinic down the road. Never going to work for us. Aren't we glad we tested it small so we don't have to waste our time doing that, making our patients mad because we texted them. Okay? So plan, do, study, act. Once you get in the rhythm of this, it goes really well. It's exciting. It's fun. And it is really important for a new team to do this, that they really slow down and work through every step of this. And something else that we'll get into in our 3rd webinar in the series about effective team meetings is you can't do this unless you're meeting. If the improvement team doesn't meet as a group, then you're sunk, because you can't do the plan, you can't do the study, you can't make the decision on the ACT part as a group if you're not sitting down talking to each other. It's just too much of a hassle, and it's also a lot less fun. Okay, so what it looks like, this is the example I just gave. So this is all the information, all the data you need, all the tracking, so you can figure out, again, all you're trying to do with a PDSA is answer the question. You have an idea to test, you're answering the question, did the test work, how might we need to change it? And you're not driving people nuts with your PDSAs because this is small, you're only doing it for 1 week. It only takes Shiloh probably 30 minutes or less to text all the moms. Okay. And then the idea is, as you continue to test your ideas, the best practices from other places, you know, some clever thing that somebody thought of in your team meeting, test it. Just go test it. That is important, and that's special. And as you get more information from more PDSAs, you move up this PDSA ramp, and then you decide again that you're done testing, and we're going to implement this. We can't keep testing everything all the time because there's lots of other questions to answer, lots of other problems to fix, lots of other things to focus on. So we're going to make a decision to implement. That means we're finished testing on this texting gift card thing. We figured out the right way to do it, and now we're going to move on. So you need to have a system for implementation as well as a system for testing. So when I see people do PDSAs and they're not doing it right, or they're not getting the full impact of it, they're going too big. They're trying to do PDSAs for all their kids with asthma at once. They're doing the PDSA over 2 months when they should really do it over a couple days or a week. They're trying to collect too much data. They're treating it as a research experiment, a large research experiment, instead of a small test where all you need is information to tell you how well the test worked and what you might want to change. And then you want to test over a wide range of conditions, which means have different staff members do the change. If more people, if all BMAs are going to be making the change once you decide to implement, you're going to want to engage lots of them in testing, not just one. If it's a change that you're testing on workflow in a visit to screen patients for exercise and nutrition habits and see if they might need some counseling or group classes about improving nutrition, reducing sugar, that kind of stuff. You might want to test that visit workflow change in the morning when it's really busy, in the afternoon when it's not as busy, under different conditions. So think about ways that these things you're testing, think about what might make them fail, and go test in that situation, in that part of your day or in that part of the clinic. And that will help you make sure that, again, once you decide to implement, you're saying, we're really confident that this is going to work long term for lots of patients. So you want to make sure that you test it under different conditions.
So we do have a couple of questions, or would you
go
like
for
to
it. Yeah, okay, go for it.
All right. So one of the questions we have is, one question an attendee has is, I always have with PDSAs, is explaining to folks the importance of making predictions. Can you assist them of the importance of that?
I agree. I think it sounded like a statement to me, and I totally agree. Yeah, predictions. What do you think is going to happen? You can think of PDSAs as the scientific method in miniature, where the scientific method you have a hypothesis. What's your hypothesis? Do we think that, you know, Shiloh texting the moms with a gift card, do we think that that's going to improve class attendance? Yes, we do. And we're going to test that out. So that's our prediction. Class attendance will go up if people know that there's a $50 grocery store gift card on offer. So that would be one prediction or one hypothesis for that PDSA. Absolutely. Yeah, that's an important to do as a team. Why are we doing this test? What do we think is going to happen?
Okay, and how do you do PDSAs in the processes that only occur once or twice a year?
I don't know. I don't think PDSAs, I don't know what that would be, but I don't think PDSAs would be that useful. Let's see. Well, you could do it, but it would take you a long time to it would take you a long time until you got to use the results of that PDSA again. So you could try a test like this year. I don't know what that would be, if it's like an annual audit or something. This year the auditors come through and we're going to do, or let's see, no, it's, I know, it's for a school-based health clinic, an example could be school registration day, right? When you're trying to get all those permission forms and all the education about the clinic and the services out to as many parents as possible on one day. So that's something that only happens annually. So you could treat that as a PDSA, and then you would just dust off your notes. You would dust off your notes next year as you plan for it. What PDSAs are most useful for are things that happen a lot more frequently than once or twice a year. So it's every day. So how does the MA help jumpstart the conversation about a kid's eating habits as she does vitals and puts the patient in the room? How does she jumpstart that conversation for the provider so the provider can then take the next step on, you know, how much soda the kid drinks or something? So how do you do these kind of handoffs? So it's a lot about handoffs, different team roles, switching tasks between each other is where a lot of the really cool PDSA work happens, because that stuff it happens every single day and every single visit, and it gets complicated or even complex when you're trying to figure out who does what and what can be reliable and what we can count on for each other to do as we think about making changes to whose job it is to do what things.
Okay, thanks, Hunter. And I know in the planning process, they want to know if you can elaborate more on why the predictions are so important.
Oh, okay. Thanks for that clarification of the question. So predictions are important. I tried to get at it a second ago. Predictions are important because you want to ask yourselves as a team what you think is going to happen. It makes it helps direct you towards what information you need to gather. So if the prediction for this PDSA here that's on the screen again, where Shiloh, we predict that's giving away $50 Safeway gift cards. That's a grocery store out here on the West Coast. Safeway gift cards will improve attendance, will increase the number of people who show up. That's our prediction. More gift cards, more people will show up. Then as she's running the PDSA for the next week's class with the 10 moms, she's going to be focused on gathering information that helps her determine on behalf of the team whether or not that prediction came true. So you'll see that in the study here, the data she collected, or the due, 7 of the 10 moms came, including 2, which was 2 better than the last one. So the prediction came through, and then she'll talk to the moms and see, let's see if they are there more, if they did show up because of the offer, or just, I don't know, for whatever other reason. So you're going to get a lot of there's a lot of individual information here that we might not call strict data, but Shiloh's going to talk to people. She's going to have an impression in addition to these numbers that's going to help. But yeah, so the prediction came true. Attendance went up. So I hope that's helpful. But what we want to predict. Should I go on?
Yeah, because we have a few, so we're just going to, if we can go on, we don't want to miss anything else that you have for this. Thank you so much.
Okay, yeah, no, this is great. I'm glad people are pitching in. Please don't hold back. So I just want to have a couple more slides left. PDSA myths, we've covered this. I still see people who do a big bulletin board, which is great, or some kind of poster in the hallway where they treat the whole improvement project, improving asthma care, improving revenue by getting more billable visits reimbursed, all this good stuff. They treat the whole project as one big PDSA. As most of you know, because of your past experience and what I've tried to communicate here, is that you're basically turning the whole project into one long research experiment with one hypothesis that you prove over a long period of time. And in doing that, it's not a bad thing. It ends up looking more like just basic good project management, which is always nice, but you're losing the power of these small, rapid cycle tests. And then another myth is kind of the mad scientist phenomenon. People learn about PDSAs and they turn around and they want to PDSA everything because they have all these cool ideas and isn't this fun? And yes, of course it's fun, and yes, of course we need to test our ideas, but PDSAs are only useful, they're only worth doing, and they're only safe. They're only safe to do, and they're only safe to do if you are doing them within this structured process we've talked about, that you are measuring to see if tests that you run that work out well when you decide to implement, you're trying to see if what you implement actually increases your measures. And it's not about doing a PDSA by itself. It kind of to the next myth too. You need to use measurement and other parts of the model for improvement if your goal is to work on, if your goal is to figure out what works and implement it in a systematic way and standardize that work so you can move on to fix other things. If you're just doing PDSAs because PDSAs are fun, you can learn a lot that way, but you're not actually going to change the way care is delivered, and you'll probably end up having to come back and think about how to improve on that exact same thing you're PDSAing in, I don't know, a couple months or a couple years, because changes don't stick unless you make that unless you use the whole model for improvement methodology together. Some people feel like they only understand PDSAs or only do PDSAs when they have a grant project or when they're in some kind of big program with external partners, other clinics, projects like the COIN program that the School-Based Health Alliance is running right now. That's great, but the clinics that really succeed, they internalize this, they get this rhythm going of improvement, and that's where the really huge benefits come through. There's a rhythm, there's a process, they know how to do change management, they talk about PDSAs in regular staff meetings. There's always somebody testing something, and it doesn't have to be part of this big project, or even, honestly, even under some big organized aim. You can just start doing PDSAs to test out a new template in your EHR system to help track things better. You can PDSA it 1 week and then share the template in a few weeks once you figured it out and once it does make sense for everybody to use it. And then this last one, PDSAs can be really awkward when you first start them. It's how our internal brains work. If I have a new commute to work, I will test just myself personally all the different routes to work to find the most efficient one. But PDSAs are what helps that process happen across a shared group of people who can't read each other's minds. So it feels awkward initially for a lot of people, partly because we do want to rush to implementation and just get it done and move on to something else. But I promise you that once you get that rhythm going and once the team gets comfortable, PDSAs become natural and they're really fun. And you can also avoid lots of arguments. If I have a good idea and Tiara has a good idea and our ideas seem in conflict or we don't like each other's ideas, we can test her idea, then we can test my idea with PDSAs, and that helps the team get along and helps us actually see which pieces of the ideas really work the best. All right, and then risks. We've covered all this already. Study as a team activity. If you think that if you do kind of the mad scientist approach, you can test it once and have fun and learn something, but you run the risk of abandoning the PDSA if you're not organized and working as a team. I'll talk about this last one for a minute. There's often what happens is there's a specific project team working on the aim, and you need to communicate to the larger clinic what's going on and why it's okay that some people are off in the corner or in the regular flow of work doing something differently today with a few patients or just one patient, what that PDSA means, and that they're not trying to turn the clinic upside down, they're not trying to confuse people, but that this is the testing we're doing. So isn't it awesome? And please learn from us, but we're not doing anything wrong by testing something small, and we're not trying to confuse you. Just let us play over here in our sandbox within the project, and don't get in our way, and learn from us. Okay. So we're going to go back to Q&A for about 5 to 7 minutes. So what did I not cover? What do you want to hear more about?
All right, we definitely want to open the question box back again on your control panel. If everyone has any questions, please take the time now to enter those questions in the control panel. Thank you. One of the questions is, do we have a sample PDSA form that we could share? During a follow-up email, we would definitely attach this with the slides. We will also upload it in 3 to 5 business days along with the recorded presentation and the slides to share with everyone. All right, Hunter, we do have a question for you. How do you start building a culture of using PDSA?
Good question. Yes, exactly. This is a way to do change management, and there does need to be a cultural appreciation in the clinic where people see the value. I think it is starting with a specific project, and you want to start with the willing. You want to start with people who have good ideas and are energetic and want to change things. So you put that project team together to figure out something that needs to happen. I think if there's not been organized quality improvement going on in the clinic, if you don't have that kind of quality improvement engine going, I think it's good to start with a clinical topic. This is just my personal opinion versus an operational topic. Let's get more money into the clinic. Often to frontline staff, their hearts and their mission, their reason for showing up to work is to really, help people get healthier and help these kids. It makes me think of the first ever quality improvement project I was invited to be part of. I didn't want any part of it because it was about improving our Medi dual eligible billing rates for our encounters with our homeless clients who did have Medicare, and it was just a few of them. And I was a righteous, kind of obnoxious new social worker, and I was like, I just want to, take care of the people and do my stuff, and that's your business, the money stuff. So that's my bias. It took me another couple of years to understand why QI was exciting and wonderful, and here I am now, filling your heads with it. So anyway, I would say start with something clinical that really matters to the staff. Start at the project level so that other people can see what the impact can be, and then people will come along as they see how these changes are really impacting care and how you're fixing things, how you are fixing problems and moving on and not just talking about the same problems year after year.
Thanks so much, Hunter. Our next question is, are there ever cases where a team does a PDSA, recommends a change, but management disagrees with the change?
Ooh, good one. I love it. I love it. Yeah, so yes. And that's something that, so initially before you do a quality improvement project, it's important to do some of the managing up or at least educating up to make sure that the leadership of the clinic understands the power of these projects, that you are going to ask for, I don't know, if you're doing visit efficiency, you may want scales in every room. If you're doing asthma work, you're going to need at some point more space for group visits for asthma, that kind of thing. And of course, the bosses can't give us everything we want, so we need to be, as a management team or as an improvement team with frontline staff and some leadership in it, we need to be realistic that not everything we ask for we're going to get. So that's one reason that the management may turn you down. There's just not the resources or the space. But the idea of what management needs to understand and what you need to have assurance of before you start a QI project is that everything, these best practices for your clinic that you've tested, you've done all this great work of testing things, that when you find something that works and you've tested under different conditions and you want to move to implementation for that change, that there will be really serious senior leadership consideration of that as part of their support of improvement work and as part of their commitment to improving the workflow overall, or the workflow and the results for the patients. So that's whoever the day-to-day project lead is, or whoever maybe the most senior person on the frontline improvement team is, that person needs to have open lines of communication with senior leadership, as well as the team needs to understand that not everything we ask for are we going to get. So there's really important lines of communication and trust that need to stay open that way. But yeah, you do not want to burn your staff out and burn yourself out on improvement work by coming up with all these great ideas that people can't answer, that management doesn't like. So there is a management culture that supports improvement, and I do a lot of training and teaching and talking about that. And it's a culture that supports frontline staff solving problems themselves and not waiting for all the answers to come down from on high.
Thanks, Hunter. And how long should PDSAs generally last?
It depends on what you're doing. Like that example, it's a good question. Often you can do them within a day. We're going to try the EMA asking 3 questions about this kid's eating habits and exercise habits as she vitalizes the patient and puts her in the room. We're going to try that today with one visit. We're going to see how long it takes. We're going to see, how the MA Should the MA just recite those answers in front of the provider? Should the MA use a form? You know, there's all these kind of things that you can test in PDSAs on this shared work of panel management between an MA and a provider. That happens within a day, or not even within a day, it happens within a visit. At least the do part. The plan would happen maybe a few days earlier and whenever the team meeting is. But if you have team meetings weekly, you can plan, do, study, and make your decision on adapt, adopt, abandon within a week. So it's like within, you know, last Tuesday's team meeting, we planned it. The MA did it on Thursday morning with her provider that she works with, and then the next Tuesday we completed it in a meeting. So the kind of the all 4 steps, I guess usually a week if the team's meeting weekly. But some though, if you're doing outreach to parents and trying to get them to sign these damn forms that we can never get them to sign, and you're doing, I don't know, texting and outreach, whatever is the cool thing you're going to do to get these forms signed, you may want to give yourselves 2 weeks for the due, because you have to wait and see, you know, who comes back. If they're mailing it back, it takes a few days for the mail to come back, or a few weeks. So it depends on what the test is. But the idea is, the questions are always, how can we make this smaller, fewer patients, fewer staff, less wear and tear on us doing the test? You want to make the test easy to do and quick to do. How can we make it smaller, and how can we make it perhaps a little bit faster?
Thanks so much, Hunter. I do want to let everyone know we have quite a few questions that are coming in, and those that we aren't able to get to. Hunter, if it's okay, can we see those questions and you can reply to everyone individually, if that's okay?
Sure, we could do that, or I could do them in a batch, whichever way you like, okay. Or I could do them in a batch, and so we could send it out as an attachment or just part of the follow-up email. Either way.
Yeah, these questions will probably be helpful for everyone, so that's a great idea. But I do want to try to get in another question or two for you. So the next one we have is, what suggestions do you have for documenting PDSAs that have been completed?
That have been completed? So yeah, use the PDSA form. It's a form that says, what's your prediction, what's your question? I should have done a screenshot of it, but most of you have seen it because a lot of you have done this organized improvement work. So use the form, and then if people really get clever with it and the communication is going on really well with the forms, you can, well, this is not this is not the official answer, but you can often move the PDSA documentation to a team meeting form where you track PDSAs in a central way as you talk about what issues you want to follow up on. So in other words, you could do it kind of more like a table versus individual forms for the thing. I know some clinics have built their own little like, I don't know, like a free blog, and have the blog with fields, or they use some kind of online survey or something like that. People have been able to put the PDSA form online so that they're not running around with a bunch of paper, and so that they can log in. If they can log in from their conference room where they have their team meetings, they could reference the online list of PDSAs that way and track what's going on. But again, you want to, whatever you do, you want to make sure that you have available at every team meeting the notes, the information from the test that just happened by whoever did the test, so that the team can do the study and make the decision on the act. So you don't lose, so much of the great stuff that happens in PDSAs gets lost because we're not documenting it and we're not being diligent about using the methodology, and you're losing all this fun discussion and exciting decision-making ability.
Thank you so much, Hunter. Since we're cutting down on time, I just want everyone to know that we do see your questions, and we still apologize that we're cutting close to time, but we would definitely respond to you, and I think it's a great idea, Hunter, sending it to everyone as a group email, and that way everyone can get the same information, because I'm sure they may have some of the same questions, definitely approaching the behavioral health care. So we just have a few poll questions. Hunter, is there anything you want to add first before we set off the final poll questions?
No, let's try to get done on time. Thanks, everybody. I hope you attend and bring your friends to Part 2 and Part 3 on April 14th and 21st. You'll see those there on the screen, and you've already had the opportunity to register for those through the School-Based Health Alliance. So thank you. I hope this was useful.
Yes, thank you so much, Hunter. And we just want to follow with some poll questions so we can definitely meet your needs within the future. So if you can just answer, did this presentation meet your needs? If you could please just take a few seconds to answer the question. Thank you, everyone. And our next question is, how well did the presentation meet the stated objectives? All right, great. Thank you, everyone. We have our next poll question is, how likely are you to apply information from the presentation in your organization? And our final question, would you recommend this webinar to others? Thank you, everyone, for attending today's webinar. If you have any questions or more comments, just please submit your questions to info@sbhforall.org. And this, again, the website will have the presentation recorded with the slides in 3 to 5 business days. We thank you, everyone, for attending today's webinar. Have a wonderful day.